So how are you students? Good, right? Always keep solving questions. That is my only request to all of you. Just don't keep reading theory and then last में जाके हम question solve करेंगे. So always solve questions on daily basis. It's okay. There will be certain questions you will not be able to answer. कुछ क्वेश्चन ऐसे होंगे जो आप बिना ऑप्शन के ही आंसर कर पाओगे, बट जब तक आप क्वेश्चंस नहीं सॉल्व करोगे आपके ब्रेन को ट्यूनिंग नहीं मिलेगी दैट दिस इज व्हाट आई नीड टू डू, राइट? So today we're going to talk about diseases of nasopharynx. We have already seen nasopharynx की anatomy. Anatomy में क्या था nasopharynx के? It was the topmost part of pharynx lined by the ciliated columnar epithelium and there was a junction of squamocolumnar area where the mucosa from the ciliated columnar epithelium changes into the squamous epithelium, right? On the lateral wall of the nasopharynx, we saw what? We saw the eustachian tube opening and the structures related to eustachian tube, that is the muscles of eustachian tube, that is your levator villi palatini and tensor villi palatini. So if you remember, this is the eustachian tube opening, right? So ye posterior part hai, this is the elevated part called as torus tuberous. Anterior part gives the attachment to tensor villi palatini and levator villi palatini, which is going on to the palate, right? Posterior part has got the Osman's pad of fat and behind this is the fossa of Rosenmuller. एक और चीज जो हमने देखी थी that was the skull base. Skull base in the children have got adenoid tissue, that is the lymphoid tissue present in the submucosal layer of the pharyngeal wall. In the adults, the adenoids regress, but certain other diseases come up. What are those things we are going to see today? We already know something about tonsillitis, right? So tonsils are also a part of the lymphoid organ and हमने देखा था कि कैसे tonsillar hypertrophy हो रहा था, acute tonsillitis क्या होता है and chronic tonsillitis क्या होता है. So based on the same lines, we already know almost everything about the adenoid hypertrophy also. हमें पता है कि एक बच्चा जो एडिनॉइड हाइपरट्रोफी के साथ आएगा, व्हाट इज ही गोइंग टू हैव? ही इज गोइंग टू हैव टिश्यू ओवरग्रोथ इन दिस एरिया, राइट, इन द स्कल बेस एरिया. एंड बिकॉज ऑफ दिस जो उसका एयर पैसेज है वो नैरो हो जाएगा एंड बिकॉज ऑफ दिस द चाइल्ड विल नॉट बी एबल टू ब्रीथ फ्रॉम नोज. वेयर विल ही ब्रीथ फ्रॉम? ही विल ब्रीथ फ्रॉम माउथ. तो ये बच्चों की टिपिकल पेरेंट्स की कंप्लेंट होती है कि बच्चा मुंह खोल के सोता है, दिन भर मुंह खुला रहता है, ग्रोथ एंड डेवलपमेंट नहीं हो रहा है और ये बच्चा रात को कई बार स्नोरिंग भी करता है. बिकॉज वी नो व्हाई देयर इज स्नोरिंग. आवाज क्यों आती है? जब भी हवा कोई छोटी सी जगह से जाती है, हम सीटी बजाते हैं तो मुंह कैसा कर लेते हैं? ऐसे करके ना एक स्मॉल सा ट्यूब बना लेते हैं मुंह के अंदर में. तो व्हेनेवर साउंड विल गो फ्रॉम एन एम्प्टी वेसल, खाली जगह से, छोटी जगह से जब साउंड जाएगी तो वो साउंड प्रोड्यूस करती है. तो क्योंकि यहाँ पे एडिनॉइड हाइपरट्रोफी है, जब साउंड यहां से जाएगी तो the space is narrow and will produce palatal vibrations. ये palate vibrate करेगा और snoring cause करेगा, right? So that is a big issue with these kids. So let us see when we do an X-ray of these children, what we will see on the X-ray of this child. We will see adenoid hypertrophy. Can you see? Now let us try to understand this X-ray. ये lateral view है of the skull. Right, this is the mandible. Can you identify the mandible? Yes, you can identify. This is the skull base going. This is the nasal cavity. These are the teeth, right? So this is the oral cavity, and this is the skull base of the nasopharynx, right? Can you see? And then this is continuing into the vertebrae, and this tissue over here, this is the adenoid tissue. My God, such an enlarged area of adenoids. So आपका ये palate जा रहा है, ये आपका skull base जा रहा है. This much is the normal area for breathing that you have. Got it? But in this child, this entire area is covered by the adenoid hypertrophy. तो इस बच्चे के पास में ब्रीथ करने के लिए जगह ही नहीं है. Based on this and the endoscopy, we grade the tonsil. अगर the tonsil, the adenoids are around 25% occupying the space, or we say it is less than 1/3 of the area of the nasopharynx, we grade it as grade 1. If it is nearly around 50% or between 1/3 and 2/3, so that is nearly 50%, then that is called as the, can you see this adenoid? That is called as grade 2. If it is nearly 75% occupying, and that means it is around 2/3, more than 2/3 of the nasopharynx, but not complete obstruction, we will label it as grade 3. and if it is completely occupying like something like this, then it is a grade 4 tonsil. ग्रेड 3 और ग्रेड 4 में तो डेफिनेटली सर्जरी करनी ही करनी है, एडिनोइडेक्टमी करनी है हमें बच्चे की, एंड एडिनोइडेक्टमी हमें करनी है तो हमें टिश्यू कहां से निकालना है, फ्रॉम द म्यूकोजा एंड द सब म्यूकोजा, नॉट फ्रॉम विच लेयर, फ्रॉम द फेरिंगोबेसिलर फेशिया, दैट इज आवर लिमिट। ग्रेड 2 वाला टॉन्सिल जो है, दिस इज अ बॉर्डर लाइन एरिया, इफ द चाइल्ड इज टू सिम्टोमैटिक, उसके अंदर में उसके फेशियल फीचर्स चेंज हो रहे हैं, तो हम जरूर उसका एडिनोइडेक्टमी करेंगे। उसका अगर डेली परफॉर्मेंस कम हो रहा है, रात भर सोता नहीं है और दिन में स्लीपीनेस आ रही है, देन वी विल डू एडिनोइडेक्टमी। ग्रेड 1 कैन बी लेफ्ट अलोन। सो व्हेन आई जस्ट सेड कि उसके फेशियल फीचर्स चेंज नहीं हो रहे हैं, तो व्हाट डिड आई मीन बाय इट? What are facial features that you will see in adenoid? एक बच्चा जो दिन भर या रात भर अपना मुंह खोल के सांस ले रहा है, तो उसके अंदर में क्या क्या फीचर्स हो सकते हैं, आप खुद बताओ। एक तो वो बहुत ही ज्यादा डल और स्लीपी सा रहेगा, है ना, his eyes will always be very very sleepy. Then उसके जो टीथ है ना, वो बाहर की तरफ आने लग जाएंगे, because his mouth is always open, so the growth of the teeth will be outside and crowded teeth. Because his mouth is always open, the palate will be very high arched. और क्योंकि वो नाक से बहुत जोर से सांस लेनी पड़ती है, द नोज इज गोइंग टू बी पिंच्ड, इट विल नॉट बी अ वेरी ब्रॉड नोज लाइक आई हैव, he will have a very pinched nose. And can you see this line in my body? This is the nasolabial fold. What is this? The nasolabial fold. And that fold will be absent in this child because the maxilla will be a little, जो दांत है वो बाहर की तरफ आ रहे हैं, तो this area is going to be very less prominent. So pre-maxilla जो है बच्चे का, that is the interior part of the maxilla, वो बाहर की तरफ protrude होगा, right? So can we have a look at one of the pictures and try and see what findings we are going to have in this child? So let us try and see in this child कि क्या findings दिख रही है हमें. What are we seeing in this child? We are seeing a sunken eyes. We are seeing the sunken eyes in this child. एकदम dull eyes है बच्चे की, right? We are seeing a very pinched nose. That means his nostrils are very small and his, जैसे हम जब सांस लेते हैं तो कैसे हमारी नाक एकदम पिंच हो जाती है, like that. The palate is high arched and the premaxilla is protruding. The nasolabial fold is absent in this child. Anterior teeth are protruding outside and there is crowding of teeth. थोड़ी सी जगह में बहुत सारे दांत आ गए हैं. This is typically called as adenoid faces. What is this called as? यानी adenoid के typical faces है. जैसे ही बच्चा OPD में walk in करेगा, you will be able to find out, okay, this child must be suffering from adenoiditis because of his typical face. He is going to keep his mouth open and he is going to have these facial features, right? Based on this, remember, we can also do the grading of the tonsillitis, right? So we can do the grading of tonsillitis also. Let us see how we can do the grading of tonsillitis. What is this? This is the tonsil. This is the tonsil tissue, right? This is the anterior pillar, the uvula, and this is the posterior pillar. So if the tonsils are well within the anterior pillar, all right, then it is called as grade 1 tonsil, and we can clearly see the posterior pillar also. If the tonsils are coming out in the oropharynx, but the distance is less than half of the anterior pillar, then that is called as grade 2, and posterior pillar is also partially seen. Grade 3, tonsils are coming to the midline but they are not touching each other. ये एक दूसरे को touch नहीं कर रहे हैं. That is grade 3. And grade 4 are when you cannot see the posterior pillar and tonsils are nearly touching each other. These are also called as kissing tonsils. Alright, they are nearly touching each other. So जब बच्चे को हम देखेंगे और tonsils nearly एक दूसरे को touch कर रहे हैं, उसको हम कहेंगे grade 4 tonsillitis. Right? So anyways. So that is all about adenoid. Of course, the treatment of adenoiditis is adenoid surgery, that is adenoidectomy. And we are going to show you a surgical video where we will discuss the different techniques of adenoidectomy and different complications of adenoidectomy. So this is about adenoids. Now let us go to another very conceptual. Now for the next 5 minutes, I want all of you to be with me and just focus on the next diagram. All right, what is this diagram showing you? This is the diagram of skull. Let us identify what is there in the skull over here. There is a sorry for this, there is orbit. Can you see this orbit? यहाँ पे हमारी eyeball होगी. This is the nasal cavity. This is the pyriform aperture, right? इसमें कोई doubt नहीं है. This is the maxillary bone, all right? This is the posterior end of maxilla. This is the alveolar arch. This is the sphenoid bone, all right? This is the sphenoid bone. उसका pterygoid plate है ये sphenoid bone का. This is forming the skull base. We call this as base sphenoid और ये उसकी pterygoid plate है. So can you see this green marked area? This area of which is marked by green color. This is a space, empty space. This empty space is behind the maxilla, and in front of the pterygoid plate, pterygoid plate, and this fossa is called as pterygopalatine or sphenopalatine fossa. What is this called as? Pterygopalatine or sphenopalatine fossa. Can we just remember this? This is called as pterygopalatine, or again I am repeating it again and again because this is going to form the base of the next two topics that we are going to do. Pterygopalatine or the sphenopalatine fossa. All right. Can we just understand again what is the boundary of this pterygopalatine fossa? Anteriorly, it is lined by the posterior margin of maxilla, and posteriorly it is marked by the pterygoid plate of the sphenoid bone, right? And superiorly it is marked by the skull base. यही फोसा, अब ये फोसा लैटरल क्या है इस फोसा के इधर, यानी मेरी तरफ क्या है इस फोसा के, this entire space is called as infratemporal fossa. What is it called as? Infratemporal fossa. Very commonly you will read a word called ITF, infratemporal fossa. This is the temporal bone going, right? This is the temporal bone. तो temporal bone के नीचे का जो area है, so in my body where are we talking about? We are talking about this space. We are talking about, can you see this zygomatic arch? This is the zygomatic arch going in this patient, right? So zygomatic arch और ये temporal bone के नीचे की तरफ जो जगह है, that is your infratemporal fossa. That is your infratemporal fossa, right? So lateral part of this is infratemporal fossa. What is going to be medial to this? Medial to this, that means अंदर की तरफ. So this is opening into the nasal cavity by a small opening, and that opening is your sphenopalatine foramen. Can you see this? Just behind the middle turbinate, just behind the middle turbinate, this fossa is opening. So can we bring these two diagrams together and then take a decision? Where are we? Can we understand the anatomy? Let me put these two diagrams together, then you will be able to understand better. So ये वही diagram है, ये वही fossa है. Laterally it is opening into the sphenopalatine, infratemporal fossa, and medially it is opening into the nasal cavity via the sphenopalatine foramen. This is the sphenopalatine foramen just behind the middle turbinate. तो स्फीनोपैलेटाइन फोरामेन कहां है? स्फीनोपैलेटाइन फोरामेन है मेरे लेटरल वॉल ऑफ नोज पे. सो दिस इज माय नोज, दिस इज माय लेटरल वॉल ऑफ नोज. कैन वी जस्ट quickly also draw this diagram and understand better on the side? So if this is my nose, sphenopalatine foramen is somewhere here, right? What is medial to the sphenopalatine foramen? The nasal cavity, all right? The nasal cavity and the nasopharynx, right? So this is medial to the sphenopalatine foramen. And what is lateral to the sphenopalatine foramen? First is the part behind the maxilla, that is your pterygopalatine fossa, and then comes the infratemporal fossa. So pterygopalatine fossa and the infratemporal fossa. So pterygopalatine fossa and the infratemporal fossa is lateral. Medial is the nasal cavity. Is that clear to all of you? अब एक और चीज समझ लेते हैं. What is anterior to it? Anterior क्या है? Anteriorly है maxillary sinus. Anteriorly is the maxillary sinus. Very good. Posteriorly is the sphenoid bone or the pterygoid plates. So this is the maxillary sinus. This is the pterygoids, the pterygoid plates. medial pterygoid and the lateral pterygoid, और उसके बीच में होता है pterygoid fossa. So that is the pterygoid plate. What is superior to it? Superiorly, that is the brain, the middle cranial fossa. Very important and very simple. There is no doubt in this. And what is above it anteriorly? That is the orbit. We have got the orbit. तो अगर आपको ये 3-dimensional space समझ में आ गई तो things become very easy for us. Let us try to revise again. Let's do it again. Can we write it down? Yes, we will write it down. What is anterior to the sphenopalatine foramen, or the anterior part to the sphenopalatine foramen is the, or the pterygopalatine fossa is the maxillary sinus. Anterior to it is the maxillary sinus. What is medial to it? Medial to it is the nasal cavity and the nasopharynx. What is lateral to it? Lateral to it is the pterygopalatine fossa, and then comes the infratemporal fossa, and just above the pterygopalatine fossa is the orbit. So that is the lateral part. Superiorly क्या है? Superiorly intracranial fossa है. We have got the intracranial fossa, and the part that is posteriorly we have got the pterygoid fossa or the pterygoid plates, right? अगर अपने को ये समझ में आ गया तो हमारे लिए ये नेक्स्ट बीमारी बहुत आसान होने वाली है. व्हाट इज द नेक्स्ट? आई एम श्योर बाय नाउ यू मस्ट हैव गेस्ड. वी आर टॉकिंग अबाउट नथिंग एल्स बट द angiofibroma. Can you see this wonderfully large mass, angiofibroma? All right. So what are we going to talk about angiofibroma? Angiofibroma है क्या चीज? Let us try to understand. Let us write down a few points and try to understand about the angiofibroma. Now this angiofibroma is, first of all, it is also called as juvenile nasal angiofibroma. इस नाम के अंदर में ही हमारे पास में 3-4 चीजें पता चल रही हैं. क्या क्या पता चल रहा है हमें? फर्स्ट ऑफ ऑल वी आर कमिंग टू नो इट इज जुवेनाइल. जुवेनाइल का मतलब बच्चों के अंदर में दिखाई देता है. सो द कॉमनेस्ट एज ग्रुप एट विच वी कैन सी दिस is at the time of puberty, that is around 13 years 14 years when you achieve puberty. So somewhere between, I will write a range of 10 to 15 years, that is the commonest age group of this disease, and it is commonly seen in whom? It is seen in males. Why so? There is a theory behind it. वैसे lot of research has taken place on nasopharyngeal angiofibroma, and if you go to read, there are lots of papers on it. लेकिन क्या हम एक्सेप्ट करते हैं? द लेटेस्ट थियरीज दैट वी एक्सेप्ट ऑन एंजियोफाइब्रोमा इज दैट देयर इज अ hamartoma. Hamartoma, this is a new word we have learned. What is hamartoma? Hamartoma means a malformation which has got multiple tissues. All right, it is not just a hematoma. सिर्फ वेसल्स नहीं है, उसके अंदर में कुछ स्ट्रोमा भी होगा, कुछ फाइब्रस टिश्यू भी होगा. So that is called as a hamartoma. And here what is happening is, people have said, the theories that have come, the latest theory was given in 1973, which said that हमारा जो pharyngeal pouches develop होते हैं, उस pharyngeal pouch में जो first pharyngeal pouch की artery है, that is your maxillary artery. लेकिन जो उसकी primitive है, the primitive maxillary artery, that maxillary artery goes via the sphenopalatine foramen into the into the pterygopalatine fossa, और वो जो प्रिमिटिव आर्टरी है कई बार वो परसिस्टेंट रह जाती है और मैच्योर मैक्सिलरी आर्टरी में कन्वर्ट नहीं होती, और वो आपका ट्यूमर डेवलप करने लग जाती है. दैट इज द सो इट इज अ hamartoma प्लस अ वैस्कुलर मालफॉर्मेशन. सो अ वैस्कुलर मालफॉर्मेशन, इसका कई बार इट फील्स दैट दिस इज अ confusing thing. How we will remember this? So don't try to remember it. Basically this is an angiofibroma. Angio means vessel and fibroma means fibrous tissue. तो इसके अंदर में vascular tissue भी है और fibrous tissue भी है. So therefore this is a vascular malformation, and it is happening under the influence of testosterone. Now if you will read the effect of the hormones on the vessels, then you will realize that testosterone has got a property of वेसोडाइलेशन. यानी कि टेस्टोस्टेरोन क्या करता है? हमारी वेसल्स को डायलेट करता है. तो एट द टाइम ऑफ प्यूबर्टी, जब मेल्स के अंदर में टेस्टोस्टेरोन का लेवल बढ़ता है, तो उस टाइम पे अगर ये कोई प्रिमिटिव आर्टरी हमारी बॉडी में रह गई है या कहीं पे एक वैस्कुलर मालफॉर्मेशन है, इट विल डायलेट एंड दैट लीड्स टू एंजियोफाइब्रोमा, So it is under the effect of testosterone and it is a vascular malformation, and that is why it is commonly seen in males at the time of puberty, right? So that is the most important thing that you need to remember, that it happens in males and it will have its peak during the time of puberty, and that is because it is a vascular malformation under the effect of testosterone. The second thing that you need to remember about this disease is that इसके जो वेसल्स हैं उसके अंदर में एक स्पेसिफिक पॉइंट ये है कि देर आर नो मसल्स इन द vascular wall. You remember vessels have got an endothelium and they've got a muscular contractile tissue and then they've got a adventitia or serosa outside it. तो जो muscles हैं वो इसमें absent है, and because they are absent there is going to be a लॉस ऑफ कॉन्ट्रैक्टाइल प्रॉपर्टी, यानी कि ये डायलेट ही होता रहेगा, ये कॉन्ट्रैक्ट नहीं होगा, और अगर इसमें कोई इंजरी हो गई तो ये ब्लीडिंग जो होगी वो बंद नहीं होगी इसके अंदर में. सो लेट अस हैव अ लुक एट दिस पिक्चर अगेन. कैन यू लुक एट दिस पिक्चर? व्हाट इज दिस पिक्चर शोइंग अस? दिस पिक्चर इज शोइंग अस अ ग्रोथ इन द नेजल कैविटी which is showing dilated blood vessels over it, and if I puncture on this vessel there is going to be no contraction. ये contract ही नहीं करेगा और bleeding profusely होती जाएगी आपके सामने, right? So what else do we understand by this? By this we understand one more point, that is you cannot take biopsy in this patient. You cannot take biopsy in this patient. You always have to rely on your clinical examination and radiological finding, right? You are going to follow what? You're going to follow your clinical acumen. आपके जो clinical features हैं, patient की history है और उसके जो radiological findings हैं, आप उसके ऊपर ही rely करने वाले हो. You are not going to take biopsy. So three things about angiofibroma that you cannot forget. One, it happens in adolescent males, young males में होता है. So history में अगर ये दिया गया है 13-year-old boy came to your OPD with recurrent epistaxis and there is a mass in the nose, your first thing should be angiofibroma, right? Second, there is no muscle in the vascular wall, so no contraction will happen once it bleeds. And third, no biopsy, only clinical examination and radiological finding. That is your important 3 points. Please don't forget. Right? So that means this tissue, this growth is happening where? It is happening over here. So let us just rub this and let us just try to see again where the growth is happening and where all will it spread. Can we just have a look over here? Yes. This growth is happening here at the sphenopalatine foramen. So what is the site of the growth? The site is sphenopalatine foramen. It happens at the sphenopalatine foramen. Now, how will it spread? If it spreads medially, then where will it go? It will go into the nasal cavity. It will go into the nasopharynx. Through the nasal cavity, it can also go into the paranasal sinuses, right? Medially, it will go where? Into the nasal cavity, into the nasopharynx, into the paranasal sinuses via these foramens, ostia. Laterally, where it would go? Laterally, it will go into the pterygopalatine fossa first, right? And then it will go into the infratemporal fossa, right? So it will first come out into pterygopalatine fossa, then into the sphenopalatine infratemporal fossa, and then superiorly also through the pterygopalatine fossa it can go into the orbit. So it can also go into the orbit, right? Superiorly, where will it go? Superiorly and posteriorly, it will go into the intracranial fossa, into the middle cranial fossa, right? So it will go into the intracranial fossa and it will cause cranial nerve palsies over there, right? So if you have understood this, you have also understood one more point, that is the staging. So let us just see this x-ray and then CT scan, and let us try to understand what is they trying to say. This is the angiofibroma, right? It is growing into the nasopharynx. This is an angiofibroma which is growing into the maxillary sinus and also into the intracranial fossa. This is an angiofibroma which is going laterally. So there is a staging that has been given, that is the Radowski staging. Radowski staging क्या कहता है? Stage 1 is the medial spread. So where is the medial spread going? Into the nose. So stage 1A is nose and stage 1B is nasopharynx and the paranasal sinuses, right? Stage 2 उसने दिया था, बहुत simple है, lateral spread. So lateral spread is into the pterygopalatine fossa, into the orbit and into the infratemporal fossa. And stage 3 was the intracranial extension. So again, mild or minimal intracranial extension and extensive intracranial extension, right? So again, can we just revise? If this is the lateral wall of nose, medially is the nasal cavity and the nasopharynx. So we're having a bird's eye view on it. Laterally, there is a pterygopalatine fossa and then there is infratemporal fossa. So that is stage 1 and stage 2, and stage 3 is going into the brain. So intracranially is stage 3. Is that clear? Right. So can we just do one more thing? Let us try to take this let us try to take this diagram a little bit more in. This is an axial view, all right, all of you with me. Where is the tumor? The tumor, see, now this is the lateral wall of the nose, right? So this is the, all right, so now this is the lateral wall of the nose. This is the lateral wall. So somewhere here will be the sphenopalatine foramen. So the tumor started from here, it went medially into the nasal cavity. So this is stage 1 cross, very good. Now laterally it went into the infratemporal fossa. This is the infratemporal fossa just behind the maxilla. This is the maxillary sinus. We will keep this as maxillary sinus. So it has gone into the pterygopalatine fossa. So this is pterygopalatine fossa is what? It is stage 2A. Then it has also gone into the infratemporal fossa. This is the infratemporal fossa. This is the pterygopalatine fossa and this is the sphenopalatine foramen. So stage 2C, infratemporal fossa is stage 2C. In this film we cannot see if it has gone into the brain or not. So if this particular film is given to you in your exam, will you be able to tell me what is the staging of this patient? Yes, this staging is stage at least going into the infratemporal fossa, so stage 2C. So it is stage 2C, right? So likewise, nowadays you will get questions which have got CT scans and you will get questions where you will have pictures to tell you what is the staging of the patient that you must know, all right? Right. On the basis of the CT scan, I will also tell you one more thing. What is that? That one more thing is that we will see also the coronal view to confirm, to correlate this. Can you see here? Can you see this is the maxillary sinus? What is happening to the pterygopalatine fossa and to the posterior wall of the maxillary sinus? The posterior wall of the maxillary sinus is bowing anteriorly. So maxillary sinus का posterior wall कैसा होता है? इस तरीके से. But because of the tumor, the posterior wall is bowing anteriorly. Can you see this anterior bowing of the maxillary sinus posterior wall? And टेरिगोपैलेटाइन फोसा तो बहुत छोटी सी जगह थी, राइट? इट वाज अ वेरी स्मॉल स्पेस, बट हियर द टेरिगोपैलेटाइन फोसा इज सच अ लार्ज स्पेस. We will correlate here. This is the posterior wall of maxillary sinus, right? It is bowing anteriorly, and what is happening to the pterygopalatine fossa? There is widening of the pterygopalatine fossa. So this particular sign on CT scan is called as Holman-Miller sign, and some people also call this as the antral sign. What they call this as the antral sign. So let us try to find out what is this antral sign and what is this Holman-Miller sign, right? So this Holman-Miller sign says that there is widening of the pterygopalatine fossa. There is widening of the pterygopalatine fossa, and the antral sign is the same thing, but they are saying there is anterior bowing of the posterior wall of the maxillary sinus. The antrum of the maxillary sinus is narrowed because the posterior wall of the maxillary sinus is bowing. So this is what you typically see on the CT scan, and that is why we remember we will not do biopsy of this patient. What are we going to do? We are going to do the CT scan of this patient. That is the investigation of choice, and what we will see the Holman-Miller sign, right? ये ट्यूमर कहां कहां जा रहा है उसके बेसिस पे उसके क्लिनिकल फीचर्स देखना कोई बहुत डिफिकल्ट पार्ट नहीं है. इफ इट इज गोइंग इनटू द नोज एंड नेसोफैरिंक्स, द पेशेंट इज गोइंग टू हैव नेजल ऑब्स्ट्रक्शन एंड एपिस्टैक्सिस, राइट? पेशेंट विल हैव चेंज ऑफ वॉइस, क्योंकि वो नेसोफैरिंक्स में जाएगा तो वो आपका राइनोलेलिया क्लोजा कॉज करेगा, right? If it is going into the orbit, what will have? The proptosis, the eyes will come out, and if it goes into the infratemporal fossa, there will be swelling on the cheek, and if it goes into the brain, there will be cranial nerve palsy. So this type of a child looks like this. What will this child look like? Will look like this. He will have proptosis, he will have cheek swelling, and he will have a broadened nose. जो नाक है उसकी broadening हो जाएगी मास की वजह से. इस टाइप के फेस को हम टिपिकली क्या कहते हैं? Frog faces. So in today's lecture we have seen two classical faces, adenoid face and frog face. Frog face is diagnostic of juvenile nasopharyngeal angiofibroma, whereas adenoid facies is diagnostic of adenoid hypertrophy, right? So this child will have broadening of nose. Even that child will have pinched nose. This child will have a protruding eyes because of spread into the orbit, right? Because of spread into the orbit, whereas that child is going to have sunken eyes. This child will have cheek swelling. That child will have indrawing of the cheek and crowding of teeth and the high arch palate. So these are the differences. What will be the presentation of the child? Nasal obstruction and epistaxis. So let us try to summarize angiofibroma. What have we seen so far about angiofibroma? We have seen that the angiofibroma develops from where? It develops from the sphenopalatine foramen, right? It occurs where? It occurs in the puberty. It occurs in males. Why it occurs in males? Because this is a vascular malformation under the effect of testosterone. So it will occur in males. The vessels do not have contractile property. The vessels do not have contractile property. So you are never going to take biopsy from this. The child will bleed profusely. आप उसको control नहीं कर पाओगे, right? How does it spread? If it spreads medially, then it will spread into the nasal cavity, paranasal sinuses and nasopharynx, and we will label this stage as stage 1. We will label this stage as stage 1. If it spreads laterally, it will go into the pterygopalatine fossa, orbit, or the infratemporal fossa, and we will label this as stage 2. And if it spreads superiorly or posteriorly into the brain, we will label this as stage 3. So Radowski 3 staging, stage 1, 2, 3. 1 is the, if this is my lateral wall of nose, 1 is the medial spread, 2 is the lateral spread, 3 is the intracranial spread, right? Very easy. इसमें कुछ difficulty है ही नहीं समझने के लिए. Where is the sphenopalatine fossa located? The sphenopalatine foramen is located just behind the middle turbinate, right? What is the typical presentation? Bleeding, nasal obstruction, and on examination you will see protruding eyes, broadening of nose, swelling in the cheek, typical frog faces. And on endoscopy, you will see this kind of a picture. And once you see this kind of a picture, red sign, red flag, don't take biopsy. What you will do, you will do a CT scan. And once you do a CT scan on the sagittal cuts, you will see a mass, you will see anterior bowing of the posterior wall of maxilla, antral sign, you will see widening of the pterygopalatine fossa, Holman-Miller sign, and you will also be able to stage the disease on basis of this, right? What is the treatment? Can we just write down the treatment? Treatment is only and only surgical. There is no medical treatment, mind you, my friends. There is no medicine that will regress this disease. You are going to surgically operate it. Now, here you have to remember that if the spread is intracranial or it is an extensive disease, then before surgery you can do something called as embolization. Embolization का मतलब क्या होता है? जो इसकी feeding artery है, what is the feeding artery? We said it is a remnant of the maxillary artery, that is the main feeding artery. तो आप maxillary artery को block कर सकते हो, उसको अंदर से हम जेल फोम्स डाल के ब्लॉक कर देते हैं जिससे कि उसकी ब्लड सप्लाई कम हो जाए, ट्यूमर थोड़ा सा श्रिंक हो जाए, बट अल्टीमेटली यू विल हैव टू ऑपरेट. Ultimately, you will have to operate this patient. That is the way. And if there is no intracranial spread, then definitely go for surgery. And this surgery can be done via various approaches. You can do surgery via transpalatine approach. आजकल तो endoscopic debridement is done. You can open the cheek from here. That is Weber-Ferguson incision, and you can swing the maxilla, maxillary swing approach, or a medial maxillectomy, lateral rhinotomy approach. So different approaches are there. In our videos on pharyngeal surgeries, I will show you a few approaches to angiofibroma. But what is the treatment? The treatment is going to remain surgery only. So if you get an option, your answer will be surgery. By which approach? That is a different question, but it is going to be surgery. Have you understood this? If you have understood this, our next part will become very quick and we will do it in just 2 minutes. That is our nasopharyngeal carcinoma, NPC, nasopharyngeal carcinoma. Just 2 minutes on nasopharyngeal carcinoma. Important points. It is a malignancy. It is a malignancy. And because this is a malignancy, it will spread. Alright, where will it spread? It will spread into the nasopharynx. We can see the name, as the name suggests, this is the superior turbinate, middle turbinate, inferior turbinate. This is the skull base, this is the vertebra, right? This is the eustachian tube opening. Behind the eustachian tube opening, we have got the fossa of Rosenmuller, right? And this is the site for this tumor. So it is arising from fossa of Rosenmuller. It is arising from fossa of Rosenmuller, right? And where is it growing? It is growing into the nasopharynx. So it grows into the nasopharynx, right? Now, because nasopharynx is a very large space, the patient will present clinically very late with the symptoms of nasal obstruction. तो क्योंकि ये बहुत बड़ी जगह है, nasopharynx is a large space, and then you have got oropharynx behind it. तो nasal obstruction नहीं होगा पेशेंट को, but because it is a cancer, it will spread to the lymph nodes. So the first presenting symptom of the patient is going to be a large lymph node. It is going to be a large lymph node. So most common presentation of nasopharyngeal carcinoma is lymphadenopathy. It is going to be a lymphadenopathy. Now, which is the lymph node that drains the nasopharynx? Actually, the lymph node that drains the nasopharynx are the retropharyngeal group of lymph nodes. These are called as nodes of Rouvier. But they यहाँ से जाएगा cervical group of lymph node में, jugulodigastric में, and that is going to present first. So the most common lymph node where it will go is the node of Rouvier, or it is the retropharyngeal group of lymph nodes. All right, and who will you see this kind of disease more commonly in? These are commonly seen in Chinese population. गुआंगडोंग करके एक प्रोविंस है, वहां पे ज्यादा कॉमनली देखा गया है. बट व्हाई? बिकॉज एक्चुअली अभी तो चाइनीज आर ऑल ओवर द वर्ल्ड, सो यू विल फाइंड द प्रेवलेंस ऑफ डिजीज एवरीवेयर. ये बेसिकली जो स्मोक्ड फिश है या वुड फायर है, वहां पर जो फायर को वुड करते हैं, सॉल्टेड और प्रिजर्व्ड स्मोक्ड फिश रखते हैं, उसकी वजह से ज्यादा जो उसमें जो एलिमेंट्स होते हैं नाइट्रोसामीन्स, दे आर नोन टू कॉज दिस डिजीज. So, but many times you will get this one as one of the option, what is Guangdong's disease, or you will get a question where one of the options will be that it is commonly seen in Chinese population. So yes, then that case it will be a you will have to remember that this we are talking about nasopharyngeal carcinoma over here, right? Now, so the most common presentation is going to be in the as a lymph node. But what else will be the presentation? Now, if you remember that here in the nose, स्कल बेस था, यहाँ पे सुपीरियर कॉन्स्ट्रिक्टर मसल थी, एंड देयर वाज अ साइनस ऑफ मॉर्गैग्नी ओवर हियर, राइट? सो द ट्यूमर कैन स्प्रेड इंट्राक्रेनियली आल्सो वाया द साइनस ऑफ मॉर्गैग्नी, एंड दैट वी कॉल एज द साइनस ऑफ मॉर्गैग्नी सिंड्रोम. What we call this as sinus of Morgagni syndrome, or this is also called as Trotter's triad, which is also called as Trotter's triad. इसमें होता क्या है? Just remember, the tumor is going to cause compression over the eustachian tube. So what will this child have, or this patient have? This patient is going to have secretory otitis media because of eustachian tube blockage. This is going into the sinus of Morgagni, and sinus of Morgagni has got the trigeminal nerve. So this patient is going to have severe pain. And this patient is going to have palatal palsy because of tensor villi palatini muscle. That is also undergoing to have paralysis. So tensor villi palatini ka paralysis, it was supplied by which nerve? Again the fifth nerve. So because of the fifth nerve, the patient is going to have pain, and the patient is going to have palatine palsy, or the uvula will be deviated, and the patient is going to have secretory otitis media. This is the classical presentation. This is the triad of the sinus of Morgagni. So the patient is going to remember this sinus of Morgagni syndrome. The triad is secretory otitis media because of eustachian tube blockage, palatal palsy because of tensor villi palatini, which was a content of the sinus of Morgagni, and pain on the chin, that is the mandibular branch, because of the again fifth nerve paralysis or compression, right? So that is the typical presentation of nasopharyngeal carcinoma, right? What else do we need to know about nasopharyngeal carcinoma? Investigation, of course, it will be CECT. CECT will be the investigation of choice. You can take biopsy to confirm. When we take biopsy, then there are two things. One, we can grade this disease. Now, grading of nasopharyngeal carcinoma has been in three ways. I mean, in three stages: stage 1, stage 1, stage 2, and stage 3. Stage 1 is a squamous cell carcinoma. Remember, what was the most common malignancy of the pharynx? It is squamous cell carcinoma. Stage 2 is a non-keratinizing squamous cell carcinoma, and stage 3 is an undifferentiated squamous cell carcinoma. It is an undifferentiated. Stage 1 has got a good prognosis, stage 2 worse, and stage 3 worst. So it is an undifferentiated. So you can grade the disease based on the biopsy. You can also tell one about the tumor marker. What is the tumor marker here? Every tumor in the body has got a marker. The tumor marker of nasopharyngeal carcinoma is HLA-A or HLA-A2 or HLA-B. So it is HLA A, B, A or A2 or B. So that is the tumor marker for. Remember this MCQ question. Tumor marker for nasopharyngeal carcinoma, HLA-A, A2 or B, right? The treatment of nasopharyngeal carcinoma, is going to be radiotherapy. Now, because this is a tumor which is highly radiosensitive, and however, you can remove the tumor, but reconstruction of nasopharynx, because we are talking about the skull base over here, reconstruction is going to be very difficult. So, the treatment of nasopharyngeal carcinoma is going to be radiotherapy. It is going to be radiotherapy, right? It is a radiosensitive tumor. It responds very well to the effect of radiation. Okay, so nasopharyngeal carcinoma ke bare mein a few things that we have just seen right now. Quickly, it is a malignancy, fossa of Rosenmuller. It presents as lymphadenopathy, very important. It is commonly seen in Chinese province. Investigation of choice is CT scan and biopsy, where you can grade the disease. Tumor marker is HLA, and the treatment is radiotherapy. The treatment is radiotherapy. Somebody asks you what is Trotter's triad. It is secretory otitis media, secondary to eustachian tube blockage, palatine palsy, and pain on the mandibular branch of the trigeminal nerve because of in sinus of Morgagni contents. So today we have seen three important diseases, that is your nasopharyngeal adenoids. We have seen nasopharyngeal angiofibroma, which was a benign disease but has a potential to spread, locally invasive we call it, and a carcinoma, that was the nasopharyngeal carcinoma. Where were adenoids? In the base of the skull, in the submucosal layer just in front of the pharyngobasilar fascia. Where was nasopharyngeal angiofibroma arising from? Sphenopalatine foramen just behind the middle turbinate. And where is the nasopharyngeal carcinoma arising from? Fossa of Rosenmuller. Right? Have you understood this? Very good. So if you have understood all these diseases of nasopharynx and oropharynx, then I'm going to leave you with one small concept here, and just in very small short brief, you understand what is something called as rhinolalia. What is rhinolalia? Rhinolalia means the contribution of nose, rhino, to the speech. ठीक है, हम जब बोलते हैं तो कुछ साउंड्स हमारे नाक से भी आते हैं, राइट, फ्रॉम द नेसोफैरिंक्स एंड द नोज. जैसे न, म, ये सारे अक्षर हमारे नाक से निकल रहे हैं. यू नो ऑफ सम सिंगर्स हु स्पीक फ्रॉम द नोज, राइट. सो दे हैव गॉट राइनोलेलिया. राइनोलेलिया मींस नाक का कितना कंट्रीब्यूशन है. जैसे कि फॉर एग्जांपल एक अपन सिंपल सा एक एग्जांपल लेके डिस्कस कर लेते हैं. दिस इज आवर नोज एंड लेट अस से द पेशेंट इज हैविंग अ angiofibroma. So there is going to be a tumor or nasopharyngeal carcinoma which is going into the oropharynx. अगर ये ऐसा होगा तो जब हम बोलते हैं या जब हम साउंड निकालते हैं तो हमारा पैलेट जो है वो पीछे नहीं जा पाएगा, राइट. एंड देयर इज गोइंग टू बी this palate, this space between the oropharynx, nasopharynx and the oropharynx is going to remain closed. So that is, दिस पेशेंट का नाक का कंट्रीब्यूशन नहीं आएगा, साउंड हमारी नाक से नहीं आएगी, राइट. दिस इज कॉल्ड एज अ हाइपोनेजल वॉइस, जब नाक का कंट्रीब्यूशन नहीं होता है. और मान लीजिए किसी एक पेशेंट है जिसको क्लेफ्ट पैलेट है, राइट, ही हैज अ क्लेफ्ट पैलेट और ही हैज अ पैलेटल पाल्सी, तो ये ओपन ही रह रहा है, तो देयर विल बी लॉट ऑफ साउंड गोइंग इनटू द नोज एंड द नेसोफैरिंक्स. दैट इज कॉल्ड एज अ hypernasal voice. What is it called as? Hypernasal voice. तो अगर हमारा ये जो पार्ट है बिटवीन द नोज, ओरोफैरिंक्स एंड द नेसोफैरिंक्स, जो हमारा नेसोफैरिंक्स और ओरोफैरिंक्स के बीच में जो स्पेस है ये क्लोज्ड है, तो इसको हम कहेंगे राइनोलेलिया क्लोजा, क्लोज्ड है ये. और अगर हमारा ये एकदम ओपन है तो इसे हम कहेंगे राइनोलेलिया एपर्टा. एपर्टा, एपर्ट मतलब एपर्चर है, एक ओपनिंग है, ऑलराइट, लाइक द पायरिफॉर्म एपर्चर मतलब एक ओपनिंग है. तो एपर्टा मींस ओपन. Because it is open, lot of sound is going in the nose and therefore it is a hypernasal voice. And if there is rhinolalia clausa, that means it is closed and therefore no sound is going into the, there is no contribution of the nose and it is a hyponasal voice. Can you tell me a few conditions where there is hyponasal voice? Hyponasal voice, अभी जो हमने सारी बीमारियां देखी उसमें hyponasal voice आएगी because of the obstruction in the nasopharynx. adenoids, hyponasal voice, angiofibroma, hyponasal voice, nasopharyngeal carcinoma, hyponasal voice. Then the tumors, I mean the polyps of the nose, hyponasal voice, tonsillitis, hyponasal voice. All of this will have hyponasal voice. Hypernasal voice, it will be seen where? It will be seen in palatal palsy. It will be seen in cleft palate. These are the conditions where you will get this. So why have I kept this particular photograph over here for you all? Now I will give you a hint. I am looking from the nasopharynx. This is the oropharynx. This is the nasopharynx. Then there is one particular ridge that is forming over here. This ridge, what is this called? Can anybody tell me? Just think about it. Yes, this ridge is Passavent's ridge. This ridge is Passavent's ridge. This ridge is Passavent's ridge. This Passavent's ridge is formed by two muscles. Which is the muscle of the pharynx at the level of nasopharynx? Yes, it is superior constrictor. It is superior constrictor. And which other longitudinal muscle is going to the posterior pharyngeal wall? The palatopharyngeus. The palatopharyngeus that was forming the posterior pillar of the tonsil also. तो जब हम खाना खाने की कोशिश करते हैं तो पैलेट जो है हमारा, ये पैलेट है और ये पोस्टीरियर फेरेंजियल वॉल है और ये ओरल कैविटी है. तो पैलेट पीछे मूव करता है और यहां पर एक रिज बन जाता है, दैट इज कॉल्ड एज पैसेवेंट्स रिज. ऑलराइट, सो दिस पैसेवेंट्स रिज इज फॉर्म बाय सुपीरियर कॉन्स्ट्रिक्टर एंड पैलेटोफेरेंजियस मसल के कॉन्ट्रैक्शन से. And in case there is a palatal palsy, even let's say ये दोनों मसल कौन सप्लाई कर रहा है? वेगस नर्व. So if there is a vagal palsy, there is let us say a case of cleft palate, then the patient is going to have incomplete closure and will have rhinolalia aperta. But if there is a mass obstructing this area, then that is going to lead to rhinolalia clausa, because it will be a closed space and patient will have a hyponasal voice, right? So is this okay? Will you remember this? Very good. So I'm going to leave you with this today. Just revise. This is a very important topic from the point of view of MCQs and also from the point of view of your undergraduate and postgraduate viva, because this is examiner's absolute favorite question, and many CT scans will come as a pictorial question from this topic as well. So please go through this lecture again. If you have doubts, post in the comments. Thank you.